Good afternoon. Welcome to the webinar of the Partnership for Food Safety Education. Today's topic is Health at Risk, Long-Term Health Effects of a Foodborne Illness. Welcome. We're so glad to have you here today, and I think that our registration numbers show that this is a topic of terrific interest, as well it should be, because we are talking about the long-term effects of a foodborne illness, something that consumers often say is a minor thing, but can in fact lead to really rather debilitating conditions. And we have two of the leading experts on this topic with us today. We're going to go through a few housekeeping matters. Very importantly, we'd like to have a robust Q&A period. So if you have a question, please use the question box, which you'll see in your panel on the right side here. Enter a question, and then when we get to the last 12 to 15 minutes, we will address some of those key questions. I want to also mention that we have attached 3 handouts, and you'll see the handout option under the questions part of the panel. There you'll find your the CDR and NEHA CEU certificates. You'll also find a great resource slide that Barb prepared that will tell you where you can get more information and some of the research behind this topic. After the webinar, you'll get a brief survey, and please fill it out. It helps the partnership improve the quality of our webinars, and it helps us understand better what you are looking for in your experience with these events that we hold. The CEUs, very important for many of you. We're going to give you multiple ways to get your CEU certificate from CDR and NEHA. You can either download it here from the sidebar, as I mentioned. In a follow-up email after the webinar, you'll have an option to download them. Or when this webinar is put up on our events page under our webinar recordings, they will be there also. We're not able to address specific emails asking for CDR or for your certificates, so we've given you multiple ways to get those. So please check that out. All right, we're going to get right into our speakers. I'm going to do a brief intro. I'm Shelley Feist. I'm Executive Director of the Partnership for Food Safety Education, and we're very pleased today to have with us Barbara Kowalczyk and Michael Batts. Barb Kowalczyk is Assistant Professor in the Department of Food Science and Technology at The Ohio State University. She's a recognized expert in food safety, epidemiology, public health informatics, risk science, and regulatory decision-making and public policy. She served on many national committees, and currently she is an appointment to the U.S. Food and Drug Administration Science Board. She's a co-founder of the Center for Foodborne Illness Research and Prevention, which is a nonprofit dedicated to advancing a stronger science-based food safety system that prevents foodborne disease and protects health. And Michael Batts is Operations Research Analyst with the U.S. Food and Drug Administration. In this position, Michael uses analytics to improve food safety decision-making with a focus on resource planning and strategic management. He's a leading expert in the area of foodborne disease health outcomes, burden of disease estimation, foodborne illness source attribution, among other topics. Prior to his position with the FDA, Michael was the head of food safety programs at the University of Florida, where he helped coordinate an interdisciplinary food safety research program. So we are going to start with Barb. Thanks so much for being with us, Barb, and we're really looking forward to your presentation.
Well, thank you. I really appreciate the opportunity to present today. So I'm going to be talking about the long-term health effects of foodborne illness. Okay, so as most of you know, food safety is an important global public good. It's critical to food security and nutrition, and has been identified as a serious public health issue. It causes an estimated 600 million illnesses per year, with children bearing most of the burden. And as we will show, it's been associated with several long-term health outcomes. As you most likely know, there's a significant impact, economic impact to foodborne disease, including medical costs and lost productivity. But there's also a loss to the market in terms of loss of consumer confidence, reduced market access, particularly for countries in developing countries, and increased food loss and waste. 2015, the World Health Organization issued the first ever global burden of disease estimates for foodborne illness. As I mentioned earlier, they estimated 600 million illnesses per year, which is in essence 1 in 10 people, that results in 420,000 deaths annually, and about a third of those are attributed to children. And these illnesses cause 33 million healthy life years lost. Now, I'm not going to talk too much about healthy life years lost since Mike's going to get into some of that. But I do want to, before we talk about the long-term health outcomes, talk about what is disease burden. So, because this is the basis of today's talk. So, oftentimes we calculate disease burden so that we can make decisions about and comparisons across diseases and populations. Now, there are two types of burden. There's the population burden, which is in essence, how often does the illness happen? And you can think about that in terms of the number of illnesses, number of hospitalizations, number of deaths. There's also the individual burden, which you can think about as how bad is the illness. So there you would be thinking about severity, duration, disability, quality of life. And lots of times you want to aggregate the morbidity, and mortality into a single measure. So you can look at age of disease or death, you can look at duration or severity of disability, and there are some different assumptions that have to be made. And Mike's going to go over that a bit more in his section of the talk. Okay, so here in the United States, we have estimated the population burden of foodborne illness to be 48 million illnesses a year, 128,000 hospitalizations, and 3,000 deaths. And that has been estimated to result in $78 billion in lost productivity, medical expenses, premature deaths, and pain and suffering. And as Mike's going to discuss later, there's some variation among those estimates. But I think the main takeaway here is that the population burden tells you how many, how often. So one of the things that we don't look at very much is the individual burden, and that's how the illness, foodborne illness, impacts individuals. Now, this is a slide that shows some individuals who have been impacted by foodborne illness. Some of them have died, and some of them have lived with have developed chronic health outcomes that they have to deal with, and we're going to talk about that here in a minute. But before, I think that there's a poll that Shelley would like us to conduct. Okay, so here, which set of long-term health disorders do you think are most associated with foodborne illness? And you can pick one of the ones listed there. Okay, so several long-term health outcomes have been associated with foodborne illness. So I don't know what the poll results were, but all of those have been associated. So we're going to go over these in a little bit more detail in a minute, but foodborne illness has been associated with autoimmune disorders, digestive disorders, neurologic disorders, renal failure, and I'm going to talk a little bit about some emerging issues. Next slide, please. Okay, so there have been several autoimmune disorders that have been associated with foodborne illness, most notably reactive arthritis, which causes painful swollen joints. And it's been associated with a number of different foodborne pathogens, which I've indicated here, but the percentage of cases that develop reactive arthritis varies by pathogen as well as by study. Now, the picture of Ryan over on the side of your screen, Ryan was a teenage boy when he contracted salmonella from tomatoes, and he developed reactive arthritis, and he spent over a year in a wheelchair, and once he was able to regain his ability to walk without pain, he still has reactive arthritis and has to take medication for the rest of his life to deal with that. Now, another autoimmune disorder that has been associated with foodborne illness is Guillain-Barré syndrome. And Guillain-Barré syndrome causes paralysis and results in death in 4 to 15% of cases in the first year of the illness. Campylobacter has been identified as a common trigger for Guillain-Barré syndrome and accounts for about 40% of the 5,500 Guillain-Barré cases that are estimated to occur in the U.S. each year. John, on the side of your screen, he developed Guillain-Barré syndrome, not from Campylobacter, but from Listeria, and still has trouble walking to this day. So as you can see, that is a very serious illness, and there is definitely a link between Guillain-Barré syndrome and Campylobacter. Next slide, please. Foodborne illness has also been associated with several digestive disorders, including irritable bowel syndrome. Irritable bowel syndrome affects 10 to 20% of people globally, and if you know anyone with IBS, you know that this greatly affects their quality of life. Now, IBS has been associated with a number of foodborne pathogens, including E. coli, Yersinia, Salmonella, Campylobacter, Shigella, norovirus, Giardia, and Trichinella. Now, it's estimated that acute gastroenteritis causes about 17% of IBS cases, and that studies have looked and found a 3 to 7-fold increase in risk following acute gastroenteritis. Tammy, on the side of your screen, she contracted Salmonella and then subsequently developed irritable bowel syndrome. She's a active mother of 2 young children, and this has really impacted her quality of life. There are some other functional digestive disorders that also have been linked with foodborne illness, including inflammatory bowel disease, which is usually classified as either Crohn's disease and ulcerative colitis, as well as dyspepsia and celiac disease. Now, celiac disease, there's not as much information on the link between that and foodborne illness, but some recent studies have shown that there is an increased risk after Campylobacter infection, and it certainly is, there's a biological plausibility there for that mechanism. But in any case, we don't have as much information on celiac disease as we do demonstrating the link for IBD or dyspepsia and certainly IBS. Next slide, please. Foodborne pathogens have also been associated with neurologic disorders. The most common ones that you think of are Listeria and toxoplasmosis, but it is, these disorders have been associated with a number of other pathogens. So sometimes the patient can develop sepsis, meningitis, respiratory distress. With Listeria and Toxoplasma, you have visual and hearing impairment can develop. Certainly there's the risk of paralysis, palsy, seizures, and epilepsy. Mariah, who is pictured here, developed E. coli 0157 when she was a young child, a toddler, and has since developed epilepsy. She cannot drive a car and deals with multiple seizures daily, all from her E. coli infection and subsequent hemolytic uremic syndrome. There's also foodborne illness has also been associated with cognitive impairment and psychosocial issues. And as you will see here, 20 to 67% of neonates who develop CNS infection go on to develop chronic sequelae, whereas 2 to 25% of non-perinatal cases with CNS infection will go on to develop chronic sequelae. For toxoplasmosis, 80% show impairment by the age of 17. Next slide, please. Foodborne pathogens have also been associated with renal failure. Most commonly, this is associated with hemolytic uremic syndrome, which can develop after an STEC infection, although it's also been associated with Shigella and other pathogens. But 4 to 17% of STEC cases develop HUS, And HUS is the leading cause of acute kidney failure in children under the age of 5 in the United States. HUS has been associated with several long-term health outcomes, which I've indicated here: renal dysfunction, hypertension, proteinuria, diabetes, and CNS dysfunction. And a follow-up study of 72 cases, and there's lots of studies out there on the chronic sequelae from HUS, but this one I found interesting. They looked at a median follow-up of 6.5 years and found that 51% of patients had at least one systematic abnormality. Now, pictured here is Ashley. Ashley developed HUS during the spinach outbreak in 2006. She's now a teenager. This was taken around the time she was ill. Ashley had her first kidney transplant about a year ago and has had a number of chronic problems that she's had to deal with. And, you know, it's important to realize that these long-term health outcomes can be very serious. Next slide, please. There are a couple of emerging long-term health outcomes that I wanted to talk about because I think that we don't really understand their impact and they have the potential to have a huge burden. One is psychosocial disorders, and they've been associated with several functional gastrointestinal disorders. But there's some interesting research looking at the risk, or the association, I should say, between toxoplasmosis and psychosocial disorders. So there was a 2015 meta-analysis of 50 case control studies that looked at the association between seroprevalence for toxo and schizophrenia, bipolar disorder, addiction, and obsessive compulsive disorder. And they found that there was a significant association there. Now, that's not, seroprevalence studies have a few problems with them, but it certainly raises the question of, you know, what are the psychosocial impacts here? The other area that's really interesting is urinary tract infections. There's been some research that suggests that some of our urinary tract infections are foodborne. Specifically, they looked at the difference between sporadic cases and outbreak cases and found differences in the types of pathogens, as well as they looked at, there have been case control studies looking at consumption patterns of cases versus controls, and they found that cases had a reported higher consumption of certain meat products. Another one that's interesting that we don't deal with too much here in the U.S., but it certainly is a huge burden globally, is malnutrition and growth impairment, particularly from foodborne illnesses related to mycotoxins. But also, you know, when you have a foodborne illness, that can impact your body's ability to absorb nutrients. And when that happens, particularly in chronically, that can lead to malnutrition and growth impairment. And if you look at the WHO global burden of disease estimates, they did show that mycotoxins had a huge burden, but there's a lot of uncertainty around that, suggesting that we need more research. Next slide, please. So Mike's going to get a little bit into this, so I'm not going to stay too long on this, but you know, so we do all this research on long-term health outcomes, and it's important for patient management, but beyond that, it's also important for our risk-based food safety systems that we're moving towards. So disease burden really, and this is a diagram that shows what a risk-based food safety system should look like. And if you see right there in step 1 and step 2, it's strategic planning and public health risk ranking. So disease burden really is the foundation for risk-based decision making. It's what helps us decide what our public health goals should be. It helps us attribute and rank risks, assess the economic impact of foodborne illness, prioritize interventions, allocate resources, and measure success. So the whole idea behind the system is that we have continuous improvement. So you need to track the burden of disease so you can see whether or not what you're doing is having an impact. Next slide, please. And I think this case, which comes from CDC, really demonstrates the impact that we have, that can happen when you understand the burden of disease. So in 1998, there was a single deadly case of listeria linked to hot dogs. And because of that, and as we learn more about the burden of listeria, changes happened. So we had new laws introduced, industry implemented changes, and you can see that from the period in the light green bar, you can see that we saw a huge decline. Now, since then, there's been other things that have been implemented that have driven further declines, but just understanding the burden of disease really does reduce the illness overall. Next slide, please. So the takeaways from my presentation are that foodborne illness causes significant acute and long-term health outcomes. This is important to understanding the burden of disease and patient management, but, and as Mike will mention, I think, in his talk, these chronic sequelae are not often included in burden of disease estimates, and that's because the strength of association is not well understood, or is not it's not been demonstrated sufficiently. And that's because there's a lack of systematic data collection, a lack of prospective epidemiologic studies. It's really expensive to follow people over time. There are some methods that we can use to get around that, such as using electronic medical records to estimate long-term health outcomes. And it's really difficult to prove causality. And so for those reasons, in some cases, certain long-term health outcomes will be included in burden of disease estimates, but in other cases they won't be. And that leads to some of the variability that we see. Next slide, please. So here's the challenge that we have. Next slide. Here's what we know. I mean, in food safety, we often talk about the iceberg. Most of what we know is just the tip of the iceberg. Next slide, please. And the challenge is we need to understand what we don't know. And that's going to take quite a bit of research. And I think Mike's going to talk a bit more about that.
Thank you, Barb. This is Shelley. My audio is back. Can operate my phone. We have a second poll for you. Please take a moment to answer this. Does this information that you're hearing today cause you to reconsider your own hand hygiene and food safety behaviors at home? Take a moment to answer. We'll leave this open for about 30 seconds. Okay, please take the quick poll so we can all see what people have to say about this. And Michelle, you can close the poll. Great. About 80% of you say yes. I also would guess that for those of us who work with consumer education, this gives us a lot of ideas and important information. Okay, thank you. Okay. And with that, Michael, we'll go back to the iceberg.
Yeah, you'll notice a theme here, Barb and I, some synergy. So thank you, Shelley and Fight Back for all you've done and for hosting me on the seminar. And thanks, Barb, for doing all the hard work. I really have nothing left to add, so I'll just skip to the end. Yeah, the iceberg metaphor is a strong one, so I'll keep using that. Okay, so I do need to start with a disclaimer. What I'm presenting today are my views, my opinions, and they shouldn't be conflated with those of the agency. Okay, so I want to start with a question. Barb mentioned it, and I want to start with it. What is a risk-based food safety system? Well, this is a risk-based food safety system. It is simple, I guess, but I actually like to start with this because even though it's a joke, it does reflect the kinds of decisions that we as consumers make every day. We take a situation, dropping food on the floor, We think there might be a risk, and we try to make sense of it. How much do I like the food? How risky is it? Did my cat lick it? Can I cook it away? Whatever it is, we're making intuitive judgments about risk. Nobody takes out a calculator before they decide if they want their burger cooked, well done, or rare, or not to eat it at all. So, the government or anybody who's responsible for risk across a large number of people, at that point it is time to crunch some numbers and try to step back and do it in a way that is a bit more consistent and systematic. So this figure, which Barb also showed, and I don't want to belabor it, but basically it shows the role of analysis in making kind of systematic risk-based decisions about where we focus our attention. So I want to start just with this first stage here. So if you think about the large number of foods we consume, the wide variety of pathogens associated with them, and the many points along the farm to fork continuum where food can become contaminated or made worse or mitigated, you get the idea of the challenge in terms of focusing attention. So where on this cube should we be focusing our efforts? This is where risk ranking or risk prioritization or these kinds of systematic activities to look across a large number of things come into play. So the starting point really is the starting point for understanding risks in this very complicated system. A good place to start might be asking which pathogens in which foods have the most significant impacts on public health. The which foods part of this question is really important. I spend a lot of time on it, but today I'm going to focus on the which pathogens part. And we're going to do that by trying to compare some of the disease burden associated with these different pathogens and including the role of long-term conditions or sequelae. So what do I mean by disease burden? There are different definitions of this. I think of it in terms of the dimensions of risk. So when we talk about risk, we think of it in terms of generally in probability and severity. So how likely is an outcome to occur and how bad is that outcome? When we're talking about that at a population level for infectious disease, we're not actually using probability specifically. What we're talking about is a rate or a count along the x-axis. So how often does it happen? So the incidence per 10,000 people or a count across the population in a given year. So the number of illnesses per year in the United States is a measure of probability. That is, on the x-axis, rarer illnesses are to the left, like say cyclospora, where more common illnesses such as salmonella might be to the right. Now, the vertical scale is a reflection of severity. So how bad is each illness? Being sick from listeria is very different than being sick with norovirus. So on a per case basis, you can think of norovirus being now closer to the bottom of this scale and listeria being towards the top. So this is this landscape of risk, and the most common summary statistics that we use to get at that are number of illnesses, numbers of hospitalizations, and numbers of deaths. Hospitalization rate and case fatality rate are very often used as measures of severity. When we come to looking at these numbers in the United States, Barb referred to this, and I'm sure many of you are familiar with the Scallon estimates published in 2001 from Elaine Scallon, who's in Colorado and formerly of CDC with CDC colleagues. These two really, I think, critical and remarkable papers come to these estimates of 48 million annual foodborne illnesses, about 20% of which is due to 31 specific pathogens, and about 80% of which is estimated to be caused by either unspecified or unknown, unidentified agents. So over 100,000 deaths in the US, over about 3,000, 100,000 hospitalizations and about 3,000 deaths. And of course, these are just the point estimates. There's a lot of uncertainty quantified around these. Okay, so back to this iceberg metaphor. So I think Barb said what we know and what we don't know. I'm using this a little bit differently. So when we talk about these summary measures of disease burden, they give us very important information, critical information about the morbidity and mortality due to acute illness. But they don't include a lot of other important things. They don't capture long recovery periods. They don't reflect long-term sequelae. they don't capture congenital disease. They don't miscarriages, lifetime neurological sequelae. They don't capture manifestations, say, where we have some questions about the causality in terms of infectious disease, or where the role of foodborne transmission is uncertain, even though we know that there's a causality has been established fairly well between the outcome and the etiology of the hazard. Other health states don't manifest for years, and some sequelae result in premature deaths that might occur very far off in the future. These are things that when we talk about foodborne disease casually, we don't think of them, and often when we talk about it quantitatively, they're often excluded. So again, Barb went through a lot of these conditions, but the point is that for each pathogen, when we're doing these disease burden estimates and we're starting at the pathogen level, there are a number of outcomes. These are just some of the most common ones. Irritable bowel syndrome and other functional bowel disorders associated with Salmonella, Campylobacter, other pathogens. Guillain-Barré associated with Campylobacter. Barb talked a lot about HUS and a number of the systemic sequelae resulting from that, aside from kidney disease, kidney failure, and such. And then, of course, we've got congenital illnesses, congenital disease due to listeria and toxoplasmosis. Norovirus has been associated to some extent with irritable bowel. Parasites such as Cryptosporidium and Giardia have been associated with chronic diarrhea and reactive arthritis, and I think as well as chronic fatigue syndrome has been associated with Giardia to some extent. There are a number of these. Barb mentioned more, and there are even more. And I think if you look at the references that Barb listed in her presentation, there are a couple of good reviews in there that Barb's been an author on that capture that. So what do we do with all this information? Well, in disease burden studies, not that you all need to be experts on this or anything, but just to get an understanding of how we make sense of this, we use what we call disease outcome trees. So we try to generalize all kind of illnesses into some severity categories, some outcome categories, mild, moderate, severe. Do people recover or do they get worse? And we start to build a tree. So a very simple tree for Campylobacter might look like this, but we know it's wrong, okay? Because we know that there are sequelae, and so we can start to build those in. There might be sequelae irrespective of the severity of acute illness, although the likelihoods of getting those sequelae might differ. So what do we do? So what we do is we basically build out trees for those outcomes. So for Guillain-Barré syndrome, there's cases that require mechanical ventilation of the lungs, those that don't, and depending on that, they have different likelihoods of returning to work and mostly recovering or fully recovering or even dying. Similarly, we can see different kinds of trees, similar trees for IBS and reactive arthritis. So what we start to do is say, okay, well, here's this more complete picture of what the burden looks like for Campylobacter. But this is a complicated tree. What do we do with this? How do I get from this to some sort of knowledge? This is just a mess. Well, what we can do is we can look at this, take some of these likelihoods, take some of the durations, take some of the severities, and use a couple of integrated disease measures to essentially summarize these trees into single estimates. There are two ways of doing that. Let's see. Okay, yeah, there's two broad measures of disease burden. Most life year approaches and monetary approaches. So life year approaches such as disability adjusted life years, quality adjusted life years, these basically use a severity times time factor. They're not, an adjusted life year, you can think of it is any health state can be scored from 0 to 1, right? Say 0 is death or 1 is perfect health. No matter what your health is, you have a health-related quality of life associated with that health state. And we can use that information to kind of, as a common metric across these health states, consider duration of them and consider likelihood to essentially get a weighted average or weighted sum across those trees. You can use a very similar approach for cost of illness or monetary approaches, which capture medical costs, lost wages, and to some extent, pain and suffering through welfare. You've heard of VSLs, or value of statistical life, that are used to value mortality. It's a controversial but necessary measure if we want to get these things on the same grounds. Now, I think the main thing with this is what these allow us to do is get a common scale. So if you want to argue or disagree about specifics of these methods, you can do that. There's a lot of debate here. But the main picture is that it allows us to compare apples to apples. Okay, so there are a number of studies for the US, and Barb alluded to this. So we have a number of cost of illness studies, some quality studies, and a DALY study. So we've got in cost of illness studies, I, along with colleagues Sandy Hoffman, Glenn Morris, and a number of other colleagues when I was at the University of Florida, published a report and a couple of journal articles in 2012 estimating about $14 billion of cost of illness due to 14 foodborne pathogens, as well as about 62,000 QALYs lost. Now, those estimates were subsequently adjusted and improved by Sandy at ERS, and they produced estimates of 15 billion due to 15 pathogens in 2015. But there are much higher estimates, both from Bob Scharf at Ohio State and from FDA economists. Travis Miner is no longer at FDA, but when he was at FDA, led this study where FDA estimated 36 billion due to all foodborne illnesses. That is, 35 specified pathogens and other hazards, along with those from unspecified pathogens. Lastly, CDC, Elaine Scallon and colleagues again estimated 112,000 dailies due to 7 leading foodborne pathogens. So there is a lot of these studies out there. I think they're all worth reading. If you're real bored. I think I don't want to be selfish, but I'll start with my own work, right? So this is my colleagues and I. This is a figure that we used in our report back in 2012, a lifetime ago. But in this bar chart, what you can see is the blue bars and the bottom axis reflect cost of illness, and the top axis and greenish, brownish, diarrhea-colored bars are QALYs. So what you can see here is these are actually ranked by a combination rank, but there's really 2 things I want to kind of get across with this. One is that when we use these different methods, we do get some differences, both in rank order and in overall sort of distributions of these scores. But at the same time, no matter which we use, we see the same 5 coming out at the top by a pretty wide margin. So I think that's important, is that we do see variation here. These are just estimates. But we can start to see that a lot of this area is covered by just a few pathogens. So this is that same figure, okay, except I'm focusing only on the QALYs, and I'm breaking it out by morbidity or mortality and by acute versus congenital / chronic. So the dark green bars are acute mortality resulting from acute illness. The dark orange bars are mortality resulting either from congenital disease or from premature death due to sequelae, and the lighter bars are due to our morbidity. Okay, so a couple things here. One, we see mortality really drives these estimates to a large extent. Second, when we do include some chronic sequelae, such for Campylobacter, they can be very significant. Now, I want to mention a couple of things here, because I talked a lot about how important it is to include chronic sequelae and long-term health outcomes in these studies, but we did not include enough. So our study did not include reactive arthritis and did not include irritable bowel syndrome. So we end up with a sort of a conservative estimate for these, because we had some issues with some of the causality and breaking down these chronic sequelae into those trees. But others have managed to do it and do it well. So this is in part, when we move in, I want to show you what it looks like when we start to include those. Now, this next slide this is not our work. This is Elaine Scallon and colleagues' work, estimates of their daily estimates for the US. And I've tried, no, this is my figure. They don't present the results quite this way. So using that paper, I created this figure to show you some of the mortality and morbidity breakdown. So here you can see dark blue is mortality due to either acute illness or sequelae. I wasn't able to partition that out, but you can see that the light blue is morbidity due to acute illness, and the large light blue, or they look a little like light gray, are the impacts of morbidity due to these long-term health outcomes, which do include IBS and reactive arthritis. So I think when you look at this and you say, okay, well, that really changes some things here. There are a couple stories, right? First, by including these, we start to see that their estimates have 3 pathogens of the 7 really dominating, as opposed to the top 5. There still is a gap, say, between Listeria and C. perfringens and 0157 in overall disease burden, but you start to see 3 things start to predominate. Now, the other point is that when you look at this, you can see that this pie chart reflects the total across all 7 pathogens, where about 50% of the total dailies are due to morbidity from these sequelae. And that does not include the mortality from these sequelae, which, as I mentioned, I couldn't partition out. So what that means is more than half of the disease burden due to these 7 pathogens is due to these long-term health outcomes. And moreover, that when you think about it, a shorthand for this is you think about diseases like Salmonella, Campylobacter, Toxoplasma, whatever you think the disease burden is, double it, because that is the role of these long-term health outcomes. I want to bring this back to something that's maybe a little bit more closer to individual, which is population versus individual disease burden. So on the left-hand axis, the vertical axis, we see total QALY loss. That's the population number. And on the x-axis, we see basically the per case loss. Now, we're running out of time, so I'd like to spend more time on this than I will. But it's just to say that things at the top half of this figure reflect those with greater population disease burden than those at the bottom. And things to the right reflect greater individual burden. And I think both of these things matter. We can't just focus on overall disease burden. There is also sort of the individual disease burden that is important, and arguably could be more important to consumers. So I just want to take a step back, circle back around and say, from my perspective, there's 2 big conclusions here. One is that when we include chronic and congenital and other long-term health outcomes, our estimates of disease burden, our understanding of disease burden goes up, and our relative rankings of pathogens might change. So I think that this is a critical component of a rational risk-based approach to food safety. As far as I think some lessons to consumers here, I know that a lot of this work that I'm speaking about today is at this very big picture level, but I think it helps to convey that foodborne illness is way more than a tummy ache. We have increasing evidence that chronic conditions are linked to foodborne infection and are an important part of the disease burden. And I also think that maybe consumers who might be willing to risk, say, a few days on the toilet, might not be so willing to risk these kinds of much more severe long-term outcomes. Lastly, I think it is important to note that some individuals who may be more susceptible to disease may also be more susceptible to severe disease and susceptible to long-term outcomes. But I think those are important messages when we're thinking about how things work for consumers. And that's really it, other than to say, no matter what data you put in front of people, people make different decisions. Some of us are Calvins, some of us are Hobbes, and no matter what information we convey, people are going to make the choices they're going to make. Thank you.
Thank you so much, Michael. I really enjoyed that, and there's a lot of good information to mine here. I've been monitoring the questions so that we could go right into Q&A. I encourage you, if you do have a question, ask it. There are quite a few really good ones that are in the queue. So I would normally assign these to you guys, but I'll try to assign them and you guys can pass it to the other if you don't feel you want to answer it. Rachel asks, can irritable bowel syndrome caused by foodborne illness go into remission over time. Barb, is that something you feel comfortable answering?
Yeah, so IBS has an interesting pathology, and IBS can go into remission over time. It's not, IBS can be. There's a lot of debate around IBS. One is the gastroenteritis that seems to trigger it. Is it part of the syndrome versus is it what triggered the syndrome overall? So IBS is a really difficult disease that it makes it hard to look at causality, but IBS can subside over time. And, that is, to my knowledge, separate from whether it was caused by a foodborne pathogen or not.
Okay, thank you. Here's a question I'll put to Michael. It's from Colleen, who asks if the statistics on deaths due to foodborne illness include loss of an unborn child.
Yeah, that's a very good and important question. So yes and no. So it depends on the study and depends on the stats. So I don't want to speak specifically to, say, the U.S. disease burden estimates because I can't remember off the top of my head 100%. But usually late-term miscarriages are often captured and treated as mortality, and miscarriages earlier in term might not be. Likewise, you're talking about stillbirths and neonatal death right after would be typically considered mortality. So those are captured to some extent by the summary measures of deaths due to, say, listeria and toxoplasmosis. But I would say there's sort of some difficult cutoff questions there.
Okay, thanks, Michael. We'll bring this one back to Barb then. This is an interesting question from Lori. Is the microbiome of interest in the risk for long-term complications?
From my perspective, yes. Of course, we know that there's more discussion nowadays about how the gut microbiome interacts with our immune system, and that's certainly one of the theories, is that when you have a foodborne illness, it disrupts the gut microbiome and then may make you more susceptible. I mean, there's also other pathways that these chronic sequelae can develop, but certainly I don't know, and maybe Mike knows of some research that's looked at the gut microbiome and how that might affect the risk of these chronic sequelae. I'm not aware of any, but I do think that it's something that we should be investigating. Mike, do you know of any?
Yeah, I mean, I think this is an emerging area. So, certainly with certain diseases, like it's not really foodborne, but like Clostridium difficile, we know about fecal transplants and impacts of the gut to dealing with those. I think this is a very growing, emerging issue. There's probably a lot of active science on it, but I think Barb, I think that's exactly where I come out, is that there's clearly something here, but the devil's in the details in terms of, maybe for certain sequelae it matters, for others it doesn't. For others, maybe there's clearly things that functional bowel disorders where maybe it's more likely to be something that's in the solution. But I think we're in early days with understanding, the microbiome and the metagenomics and a lot of these kind of big questions that get at sort of really individualized treatment options and things like that. It's, I think, a very difficult question, but I think it's, yeah, I wish I had a better answer, but I think it's best to just classify it as something that is an area of very active research.
Well, yeah, clearly this there's a lot to be further explored here, and I'm sure all of us are hoping there's work being done. We have a comment from Jessica, who just says no questions, just wanted to say this was a really fascinating talk and good speakers. Let's see. Elizabeth says, I noted there was not much research on celiac disease and foodborne illness. if I wanted to follow this topic, where would I look for that research? Michael, you want to handle that? Or either one of you?
Yeah, I'm trying to think of the best place to start. I think probably the best summary of this, and I don't know if this is the review that Chad Porter and Barb and Mark Riddle did, which is in Barb's reference list, talks about the associations between celiac and Campylobacter. That might be, for me, where I would start to look. I'm not as familiar with the literature on that. And again, that's probably something that's still emerging, but that's where I would start.
Yeah, it is. It is an area that's still emerging, and as we pointed out in that review, I haven't checked to see if there's been any new studies that have been published. I don't know if there are studies ongoing, but you know, there's only been a little bit of work done looking at the risk between celiac disease and and it looked at Campylobacter, but it's certainly biologically plausible that there might be a pathway there. So I would check out the review that's on that list, and then you know, I don't know. Sometimes we will put out information on updates to long-term health outcomes, but I think that's an emerging.
Oh, I'm sorry, Barb. I was just going to say that if you have additional questions or specific questions, I'm sure I speak for Barb too, saying feel free to contact us and we can help you with with specific questions like this, especially where I know it can be hard for you guys to access this journal literature. So we can help facilitate that. I'm happy to help do that. So I'm sorry for interrupting, Barb.
Thank you both for that. We do have some additional really good questions, but we probably should close up here. If you want to advance the slide, we'll go to our closing. And thank you all for participating, providing the questions. The Partnership for Food Safety Education is really a source for consumer food safety education. We use these webinars as a way to support the educators, because the more informed educators are and the more they feel they have their questions answered, I think they are in a better position to support consumers. So at fightback.org, you'll find a lot of free downloads and information for consumer education. Next, I want to just acknowledge there's also some fantastic resources through the federal agencies at foodsafety.gov and the FDA Center for Food Safety and Applied Nutrition. You'll find a lot of depth on particularly at-risk audiences, people who are most at risk for these more serious long-term illnesses, pregnant women, older adults, cancer patients. So please check out those resources. They're free to download and free to order. I want to acknowledge that our sponsoring partners help make possible this kind of programming. So I want to call out Cargill, ConAgra, the FMI Foundation, NSF International, and the Produce Marketing Association for their support. We are also lucky to have the support and the active engagement of all these partners who serve in many capacities, including with expert input and collaboration on getting out the message. Our community connectors are a special group of supporters who make sure that we have what we need to serve you, to serve our backfighters with programming like this. So thanks to them. And I want to make sure you know about our next webinar event, because we're actually doing something different this year. We are doing a series of 4 webinars on the topic of behavior change and behavior change theory, and really helping with some of the building blocks for how you might approach your consumer education and outreach. The next webinar is April 18th on the subject of behavioral economics. Our first in the series was in February, and the recording can be found at fightback.org under events. So please join us on the 18th. This is a fantastic series and really gets into behavior change theory, and we will also present some food safety case studies in those webinars. Finally, again, the survey will pop up right after we close here. Please respond. It is so helpful to us. Remember also here under handouts, you can get your CEU certificates for CDR and NEHA. So thank you for responding on the survey. And thanks again to our outstanding speakers. Thank you, Barb. Thank you, Michael, for being with us today. Really appreciate your time and how much thought you put into presenting this topic. So thank you all. Please join us on April 18th, and we look forward to it. Thanks, Michael. Thanks, Barb.
Thank you. Bye.
Bye.
Bye-bye.